Folks, that might be a quorum, and I'm sure people will join as they are able. So again, thank you very much for taking time out of your day and your schedule, making time to join this Providence, Alaska Echo Dementia virtual clinic, telementoring clinic. And this is our third session. And I'm guessing we've got some folks who were here the first time. I see some familiar names already. And if this is your first session, welcome. I am going to share my screen. By way of introduction, while I'm doing that, I am Kristoffer Rhoads. I'm a neuropsychologist here at University of Washington School of Medicine, located at Harborview, and your facilitator for today's session. So hopefully, I've been having a little bit of Zoom trouble this morning. Hopefully that looks okay. All right, I see some heads nodding. All right, so again, welcome to session number 3. This is very much a joint project with multiple hub team members in multiple locations. We'll do some introductions in a second, just so you know who comprises this group. And I do want to say a couple of words. You saw some CME screen scrolling there as you joined. We are able to offer CME through Swedish Medical Center, which again is accredited, not just accredited, but with commendation. We have no disclosures that are relevant. And that's true for our speaker today, which is me, and our planning committee, which are listed here. If you are claiming CME, CNE, I believe you have the code there in red. There is the link to click on. And of course, you should only claim whatever is commensurate with your participation and time spent. And that will be active immediately following this. Okay. So for our agenda, number 1, we'll do some opening notes and reminders. I think we're all Zoom fluent at this point. We'll introduce the hub team. We will also move then into the didactic, which is around early and accurate detection and delivering the diagnosis, which I am pleased to offer today. We do not have a formal case. We would love to have your cases come forward. Dr. Eisenberg has graciously offered to do a very brief vignette to get a conversation started. So maybe you know, the less didactic learning can happen via a conversation of what you're doing well and what works for you. And we'll do some very brief closing notes, and then you'll receive information for an evaluation afterwards. The other thing I wanted to do, maybe before we go any further, I'll stop sharing here for a second. We realized fairly recently that our next scheduled session is on the 21st, which is a holiday. And out of respect for your time and your lives, we thought, well, we could do that if it works for the majority of people here, best interests of the learning committee, or we could move it to the 28th. So we are going to engage in a democratic process here and see what people want to do. So far, it's looking like a strong move it to the 28th. Vote early, vote often. We're at 81%. Oop, 74%. We'll keep the polls open for another minute or so. We've got almost 70% of people participating. Over 70%. We'll get up to about 80 maybe if you were able to do so. But it's looking like move it to the 28th would be the preferred. Yep, we can round up there. Okay, so by a landslide, you have voted to move it to the 28th. So we will do that. That was my preference. I didn't want to bias your vote in any way. Okay, so let me reshare. So we'll send an email out as a reminder there. But thanks for that, and enjoy hopefully a full day off. Okay. So again, the principles of Project Echo are all teach, all learn, bi-directional collaboration. And we are deeply interested in what you do well in your areas of expertise. And that if you are able to share your knowledge, if you're in a place to do so and can turn your camera on also, that's wonderful and appreciated. And then, of course, protecting all PHI. And then I will refer you back to the website. I'm going to refer to some previous didactics, some of which are on the Mountain Pacific website. So go with that. All right. So next we have, we'll do some introductions. I have already introduced myself. I will ask Nancy to go next.
Hi, everyone. Nancy Eisenberg, cognitive neurologist at the Center for Healthy Aging at Swedish and co-lead Project ECHO. I would like to call on Kimberly.
My name is Kim Young, and that's my Yupik name is Arayach, and I'm from Napakiak, which is on the Kuskokwim River in Southwest Alaska. I work for the Alzheimer Resource of Alaska, and I'm really happy to be here. Thanks.
Great to have you. All right, how about Jordan?
Good afternoon, everybody. My name is Jordan Lewis. I'm Aleut from the native village of Naknek in Southwest Alaska. And I am currently the Associate Director of Memory Keepers Medical Discovery Team at the University of Minnesota Medical School in Duluth, and actively involved in a lot of work in Alaska still.
Outstanding. And we will tie some Minnesota related things to this didactic in a few minutes. And then how about, I'm not sure if Ursula is here. I have not seen her yet. Going once, going twice. Okay. And how about Kyla?
Good afternoon, or yeah, I guess it is afternoon. Everybody, this is Kyla Newland, and I am a pharmacist at Mountain Pacific Quality Health. Thank you for having me.
Great to have you. All right. Yeah, and if it's not afternoon, it will be shortly. So time is non-linear. All right, so let me reshare my screen here as we move to the didactic. All right, that looks okay. Oh, and then I want to acknowledge all of our participants. And if we had the time, it would be fantastic to go through and hear who you are, what you do, and where you are, and with whom you work. But last count, we had over 120 people registered throughout the state, representing a huge swath of provider types and backgrounds and experience and expertise. And again, we really want to elicit as much of that as possible as we engage in a conversation today. So the topic will be early and accurate evaluation, and I thought we'd focus on some very kind of skill and tool-based case detection, all the way up to how you talk about the diagnosis. So this is very upstream, not quite as far as upstream as prevention, but pretty close. And my hope is that at the end of this, you will have a better sense, we will have a better sense of the cognitive screening measures that would be appropriate for use in primary and specialty care settings. During the first session, somebody asked in the chat, and I'm sorry, I don't remember who, somebody asked, what is the best measure to use? And my answer at that time was, number one, we'll talk about it in the next couple of sessions. And number two, it depends on the person in front of you. So we'll talk about that. I also am hoping we'll have a better sense of evidence-based objective measures of function, which are critically important to assess, and then to talk about the core components of how to effectively and compassionately render a diagnosis in a culturally sensitive and appropriate way for the people that are in front of you at that time, and then ways to revisit that. So I don't probably need to convince you of this, but I wanted to provide some information and some references around why early detection and diagnosis is important. Of course, consistent with our first didactic, we want to rule out things that are treatable, modifiable, or arrestable. We want to make sure people have a diagnosis that enables them to connect with the supports and services that are available. We also need to recognize dementia as an index variable that modifies how we manage other things like diabetes or heart disease. There are raised risks around hospitalizations, ER visits, and how that contributes to other unanticipated transitions in care, and also to give people a chance to plan. So as early as possible, with cognition as intact as possible and capacities preserved, what do they want end-of-life care to look like? What do they want, other, big decisions to look like? And then there's also lovely data that would say the non-pharmacological things, some of which we've already talked about, are more effective the milder the symptoms tend to be. Not that they're not effective once somebody's hit the stage of early dementia or maybe mid-stage, but boy, it's a lot easier to engage in behavior change and put some of these things in place when you've got the cognitive scaffolding to do so. I would offer you that the basics of dementia assessment are a very careful history that is foundational. a robust physical examination, neurological examination. I'm not sure if Dr. Eisenberg would argue, but I would say a primary care provider, a well-trained primary care provider can do an excellent neurological exam to rule out some of the most common things. There needs to be some degree of objective cognitive assessment. And as a neuropsychologist, I would guarantee you that you do not need a neuropsychologist to do this. You probably shouldn't have one in some cases, as we tend to overcomplicate things. You need a functional status assessment, screening or an assessment of depression, and labs. So that's the basics. Not everybody needs a neuropsych eval. Not everybody needs neuroimaging. We can talk about those later on. And then sometimes people need time, right? That things are unclear and there are things to work on. So we're going to repeat some aspects of this in 6 months, maybe 12 months. The interval will be dictated by the degree of clarity or things that need to be ruled out. So the things I wanted to focus on today were the history piece, the cognitive assessment, the functional assessment, to give you tools around how to implement those in your practice. I also want to remind you in the mass grading conditions that we are always assessing things like hearing loss, vision loss, the metabolic things that we've talked about, sleep disorders, all the things that we talked about in session 1. So there's a reminder link there, or if you missed it, that was really kind of the focus of our first didactic. When I think about sitting down with someone, and one of the luxuries I have is time with patients and families to talk about changes, right? Are these, they all occur in a cultural context and a milieu that is critical to understand, where does this person come from? What was their baseline background kind of level of function? What's important to them? What was their occupational or other kind of previously enjoyed activities? How did these things start? So was it gradual and insidious versus something that was datable, like a medication change, or something that was co-occurring with some motor symptoms like a stroke? Is it progressive? Is it static? Does it fluctuate? So again, we're thinking about Lewy body disease or maybe other things that might be contributing. Are there other symptoms that are co-occurring, like hallucinations or delusions that may now strengthen the possibility of Lewy body disease or Parkinsonian symptoms? How are these symptoms impacting the person? Their independent activities of daily living, their basic ADLs, the things that are important to them, their role in their family or community. And these are often kind of the things that provide guidance for treatment. Where are you going to put a lot of your efforts, things to improve day-to-day function. And then, of course, are there other co-occurring changes like, sleep inversion or difficulty with other daily activities? Typically, I do not, we always ask about things like substance use and driving. I try not to ask about those until the very end, just as a chance to create some rapport and sense of trust. And sometimes it's not the first visit that you talk about these things. You might plant a seed and then revisit them. And I cannot stress enough the importance of gathering the same information from the care partner or family member or a close friend who knows this person well. And ideally, to have a venue to do that independently. Very, very often, well-meaning spouses or adult family members won't tell you the full story because it could be shameful, it could be embarrassing, it could be perceived as disrespectful. So really having a good eye towards how do you gather this information in a way that's appropriate for the people in front of you as a family or as individuals. And of course, people need time. This last point of, these aren't easy conversations to have. And I usually preface this conversation by, this is not like we're going to come in and talk about your blood pressure and cholesterol. So I want to acknowledge that. And then, of course, you repeat this across sessions. You might come back to some topics and see a consistency of answers. And these conversations, this history gathering really sets the stage for, well, just like when you come in, we measure your blood pressure, you've got concerns about your memory. So we're going to do a memory assessment as well. That this is just a natural part of the visit. So if we shift into the tools that we have, many people still use the MiniMental status examination. It's often, what people were trained on when they went to medical or graduate school or other settings. I would encourage you that there are some better instruments. This was a landmark instrument in 1974. This is 50 years old. And it was, again, it was a great step forward. But as you can see, it's not the most sensitive, and it's certainly not the most specific, particularly if the person in front of you is not Caucasian, primarily English speaking, with at least 12 years of education. And you can improve the utility of it by getting some normative data around age and education level. You can improve the utility by adding a few other measures, but it still has hugely problematic false positive rates for non-Caucasian folks. It's 7 times as high. So we've got better tools, but it's out there, and certainly people are familiar with it. And if you use it, I'm not, saying you shouldn't. You should be paying for it because it is also copyrighted. But you might consider augmenting your armamentarium with something else. The other widely available measure that came out of the University of Washington here with my colleague, Dr. Sue Borson, is the MiniCog, which is very simple in that it's a 3-word. I'm going to give you 3 words, say them back to me so I know that you know them. Now I want you to draw me a clock with the specified time. Okay, what were those 3 words? And it's brief. It's got pretty good sensitivity. And there are a couple of things, algorithms that you can think about here. What it was not designed to do, though, was pick up on MCI. So it's a good measure for frank dementia. And it has fewer education, cultural linguistic kind of problems compared to the MiniMental, but it's still, for early detection of early change, maybe not where you'd want to go. That would lead us to something like the MOCA, or the unfortunately named SLUMS, the St. Louis University Mental Status Examination, which are way more robust. The MOCA remains the gold standard. The SLUMS is pretty close, although with less validation data. And this is, again, like a 30-item measure. So you get a score that kind of is familiar if you're familiar with the MiniMental. The cutoff is 26. It should be slightly lower in community settings, maybe 24, 25. Cutoff will also vary depending on language and education. As you can see, the sensitivity and MCI is vastly superior to the MiniMental, and specificity is pretty excellent. There is also the most recent version, and many people are already familiar with this, and you can find out more here at the website, but this MIS score is very handy. So, instead of just a 0 out of 5 for the delayed recall portion, you get a series of points if you can get the item with the category Q. So you get 2 points if you can identify it with the category Q, you get 1 point if you can pick it out of the multiple choice. And the higher that score is, the more likely it is to be a retrieval problem, typically associated with vascular cognitive impairment or maybe depression. If that MIS score is really low, that's more of a cortical dementia. So that's, there's a clear encoding or a storage deficit versus retrieval. So some nice additions there, and continues to undergo revision. There are also versions over here on the right that can be administered over the telephone or via telemedicine. We have done many of these as part of our research studies, and having looked at hundreds at this point, they hang in there pretty well with the full MOCA, especially for people with mild impairments and with good, kind of either phone or video connections. They also have some guidance about how to do the full MOCA over video. There are translated versions, alternate forms. There is also a really lovely First Nations, Vancouver Island Coastal First Nations version that has been modified to be more culturally meaningful and appropriate. Hard to find information about this. It's clear who modified it and adapted it, but I have not been able to find any reliability or validity data or much else about it other than it's a really lovely adaptation with more culturally appropriate naming stimuli as well as words and abstraction. So a nice effort to make this more valid. Also, if you're not aware of this, this is a favorite of mine, something we use here at Harborview, given that we see a lot of people who do not speak English and have 0 to 6 years of education. the RDOS, which comes out of Australia, and was designed to minimize cultural, linguistic, and education effects. It still operates on that 30-point scale. It's pretty brief. And with a standard cutoff of 23, it's got great psychometric properties. It's pretty good at ruling dementia in. The GP cog is actually better at ruling it out with your likelihood ratios there, but it's still pretty good. And there are emerging studies in the last year and a half. There are 4 studies that have looked at the RDOS and MCI, 2 in Thailand, 1 in Peru, and 1 in Mexico, but not a ton of data yet. But stay tuned, it seems to be emerging. But it's a really, it's a great instrument to have if it fits for the person in front of you. If we shift to functional assessment, Jim Galvin created the 88 way back in 2005. This is also very nice in that you can give it to the person with memory loss or dementia, and you can give it to their collateral, and you can compare and contrast scores. And it is pretty good at distinguishing dementia versus MCI, and certainly any cognitive impairment from normal function. So that, and it's very quick. So that's a great instrument, as is the FAQ. This was an earlier, this is back in the 80s. Sensitivity and specificity are, similar to the MiniMental. It was kind of used in tandem, but it's a functional ability change over the last 4 weeks. The challenge with this is it's a little hard if you don't have a chance to do it as an interview kind of a format. It's hard to know if some of these things are due to sensory problems, motor problems, other physical limitations versus changes in cognition. So you have to be a little clearer about you're really pulling for, I'm having trouble with these things because I'm having trouble with my cognitive functioning, and it's a change. This is not something that's been true for a long time. So it can be modified, but there you go. How do you actually implement this? I would encourage you to think about setting up a 2-step process where you may have something that's very brief built into a visit like the Medicare annual wellness visit. Or if you have a concern as a provider, or if the patient or person with memory loss and family have a concern, that you've got something you can bring out. If it's normal, you may, still assess some other things and say, well, let's keep an eye on this. If it's abnormal, you may send them to do the relevant things like labs or hearing evaluation or sleep study or maybe imaging. With the plan to bring them back for a more comprehensive evaluation, which might include the MOCA and the FAQ or the 88. And with that kind of a setup, I would encourage you to think about the CPT 99483 option, which is the Comprehensive Cognitive Assessment and Care Planning Visit. It's a bit of a lift. I will not lie to you that way. There are a number, 10 of them, required service elements and documentation. It can be done by a variety of, that should be a capital A on PAs there, providers. It is time-based, but it reimburses incredibly well with a work RVU of 3.8, estimated revenue of about 265, and it can be billed every 180 days as appropriate. You can also add extended billing codes onto it. So if you're interested in this, it does take some work, usually with your EHR and your who's going to do what. There are parts that maybe different provider types could do, or even office staff. But then how do you document that? And then how do you make sure you're in compliance? Dr. Eisenberg did a lovely didactic as part of our UW Echo series. The link is there. We also, as part of our Dementia Action Collaborative, borrowed heavily from the Act on Alzheimer's group in Minnesota, which came up with this great cognitive impairment flow sheet. We took that, modified it with tools that we liked and that felt appropriate for our population here. There's 3 other pages that talk about what to do next if something's abnormal, but it gives you a sense of, okay, here's how you might set this up. So something to think about, some resources if you're interested. Again, it does take some thinking and some lifting. I think I could say this with confidence that we also have some Epic and other EHR tool templates that I would be happy to share if they're helpful. You can also find some resources through the Alzheimer's Association. And as much as I may take issue with some of their approaches on things, I do appreciate how much they have offered a really nice, comprehensive, if you're going to do cognitive assessment, here are the measures. They're all in there. They also have a nice overview of how to do that care planning visit and a fact sheet. So those links are there. Okay. So you've done all this, right? You've done the diagnostic visit or visits, you've done the labs, you've done imaging, you've ruled out all the things you need to, you've ruled in the things you need to. How do you then deliver this diagnosis? I also want to start with what's offered through the Alzheimer's Association. And the thing I like about this Principles for a Dignified Diagnosis is this was created by people who had a diagnosis or family members. So these aren't the quote unquote experts that are doing the diagnostic process. This is what people living with the disease would want. And first and foremost is absolutely to continue to talk to the person living with dementia. And you probably have stories. We have tons of stories of as soon as the diagnosis was rendered, everyone's now talking to the spouse or the adult child, like the person's not in the room. And that is extraordinarily upsetting for people with cognitive impairment. And my experience, I typically work with people up into the mid stages, and I work with families in the late stages, is that does not change. Even in the mid stages, they are in the room, they are present. They might not be tracking everything or remembering everything, but boy, it goes a long way to maybe convey information through that person, because the people that are with them are going to hear it. Telling the truth, including what you know and what you don't know, and how you can know it and can't know it. That it's not 100% certain. Maybe people would really want to be tested early, and that memory concerns are taken seriously regardless of age. I'm sure you also can think of plenty of people who have the story of, well, I went to see this provider and they said, well, you're 85. Of course you're going to have memory problems. Maybe. Or, I'm 60 or 55 and, oh, you must just be kind of worried well and maybe anxious. So memory concerns seriously at any age, using plain but sensitive language. I think sometimes we, A, get used to jargon, and B, feel like it's a little bit of a suit of armor in a way that we are kind of in the expert seat. People with dementia also would want a diagnosis to be rendered and given in conjunction with other providers. So coordinating with primary care providers if you're not the person's primary care provider, or maybe coordinating with their audiologist or their sleep medicine doc or their service providers out in the community. Explaining the purpose and reason for why you're asking someone to do something like MRI or cognitive testing or a lumbar puncture, if that's the road you go down. Providing tools for how to live well, as well as a plan for how to live well. And then probably this should be at the foundational position here, is recognizing the individual. One of my favorite mentors 20 years ago, who was a well-known, well-recognized individual in the field of dementia, said, you've seen one person with dementia, you have seen one person with dementia. And that is all you have seen. This disease unfolds so differently. And then appreciating that this is a journey, not a destination. So a diagnosis is not the, well, there you go, here's your AirSep, good luck to you. But we are on this together now, and I will walk this walk with you, and we'll do the best we can with this. There's the link if you want to read things in more detail. Also appreciate some work that comes out of the oncology world about delivering bad news. And Spike's model is a good one in terms of how you set up the environment, getting a sense of people's perceptions and what they know, asking permission around, what do you want me to tell you? What's your best, do you want me to write this down? Do you want to hear it verbally? Do you want to see some pictures? How much do you want to get into? You just want to get to the bottom line or go over things in detail? Again, avoiding jargon, providing chunks of information and checking for comprehension, empathy, which we all, the fact that you're doing this work, you carry that with you, right? We all are doing this for the right reasons. And then the summary. And I think one of the things that I am guilty of sometimes is the kind of skipping the empathy piece to get to the summary piece, and like just to let people sit with, this is not the diagnosis they wanted to hear. and they need time to process that. And they don't necessarily want to jump right to the, well, here's what we can do. You know, here's the bad news, but here's the good news. Here are all the things we can do. You know, that, are you ready to talk about that? And if they say no, then that's a later visit. And okay, we can go over the diagnosis and we can kind of deal with that in the moment, and then we'll get to that. So that again comes out of the oncology world. And a couple of years ago, there was a proposal to modify it for dementia. And again, I'm going to point you to one of our UW echo didactics, if you're interested in this, done by my colleague, Dr. Parsi, talking about that, you know, it's the setting, you know, kind of each one of these pieces modified for dementia, including, you know, with the knowledge, conveying the continuum that, you know, well, this is a diagnosis of early stage dementia. And boy, that tends to move very slowly. And then there's mid stage, maybe late stage, and avoiding drop by drop information, which can be confusing and hard to stitch together by people with cognitive impairments. So I will direct you to that too. Really nice kind of an overview of how to set up a visit like that. And then once you've rendered the diagnosis and realize that you're going to have to come back to this again and again and again. We were talking earlier that, you know, we have an 1.5-hour visit family conference with a provider, nurse practitioner, social worker, as many family members as the person wants to have, or friends or whoever, either in person or virtually. Go through this very emotional, difficult conversation, follow-up visit a month later, no recall of it whatsoever. The family does, but the person with memory loss not. So how will you revisit this? And, you know, can it maybe be a little bit more factual? Like, well, you know, at our last visit, this is what we talked about, and here's, you know, here's where we're headed with this. And consistent with this, we need to give people resources. So I want to point you to the Alzheimer's Resource of Alaska, and I feel a little. I mean, Kim, I don't know if you want to jump in here. I'm stealing your thunder, but you know, we have folks from Alaska that come down all the time, and I had heard of the ARA well before Echo Dementia Alaska, and all the great things that are happening up there. So we've got like education all the way from support groups to these cognitive activation programs. One of the only resources that provides mini grants that I know of, really wonderful care coordination work, consultations, memory screenings, some virtual memory cafes that are happening right now. And I mean, just looking at the calendar tells you how much they do and what a great service. I also want to point out that not all of these things are available in all parts of Alaska, but they should be your go-to, one of your core resources that you're providing people. I also know that you have a Dementia Action Collaborative up that way. I don't know exactly. I was having a hard time finding all the things because I was pressed for time. I'll point you to some of the things that we've come up with. And if you have versions of this up there, please replace those or these with those, and let me know. I'm always curious. We've got a great kind of an info kit, dementia legal planning toolkit, roadmap. And again, it's easy to overwhelm people with information, connections to, you know, programs and other services. I wouldn't encourage you to do that, but to have these things available as they are relevant and appropriate. And some of the things that I have here are a little bit Washington State specific, but there are some things in there that translate. So I've got some other references and resources here. Thank you for your attention. And again, there's my contact information. All the links to those things are active. I just checked them this morning, so you'll get a copy of this. But I'm always happy to send out other things. And I am going to stop sharing. And got plenty of time for some questions. If you have them, feeling free to unmute and you know, maybe say your name, where you are, what you do. And I would also be deeply curious about, what do you use? What's been helpful for you?
Dr. Rhoads, this is Gay Wellman with ARA, and I just wanted to jump in real quick here. I'm actually on the committee that's here in Alaska that's working on those plans, that the roadmap and the legal and financial planning. We have pretty much completed our roadmap, and we did use yours as a base, but we've made it more Alaska friendly, I suppose you might say. And we have a wonderful woman who's working on a wonderful book of financial and legal planning. And so stay tuned, stay tuned.
I am so happy to hear that. Thank you so much for jumping in. I figured it was in process, but you know, each state is kind of in a different place and with different resources. So glad to hear that. Yeah, and it needs to be Alaska friendly. I mean, there's a reason we have a Washington State one, right?
And it is a bit of a challenge not to overwhelm.
It is. It is.
So we did struggle with that, but it's a great committee to be on. It's a state committee and lots of different people involved. So it's been really great to be involved in that.
Outstanding. Glad to hear it. And I for those of you who are with the ARA, if I've underrepresented or misrepresented any of your services, please let me know. Jump in.
Did good job. We're very proud of it.
Yeah, you should be. Yep.
Thank you, Chris, for that terrific talk. Gosh, I mean, so much was covered in terms of the tools to use, the assessment, and then how to really be with the patient, the family, the person who's living with the challenges, to slow down. So useful, so helpful, so indispensable. There's a question in the chat from Kristoffer. Can you unmute yourself and pose the question, or I can read it? Hi, thanks,
No,
Kristoffer.
I can definitely
Great.
be able to read it and ask it. So again, my name is Kristoffer Rhoads, and I'm a palliative care physician at South Central Foundation here in Anchorage, Alaska. You know, one of the questions that typically come up, I guess I have a couple of questions. One, I know there's a lack of evidence for routine screenings just to be integrated like in the geriatric setting. And so it sounds as though it's best to do screenings when there's flags or cues that there might be cognitive impairment. So that was one question. And the second question I have is, I know that there are some cognitive screens that are better for longitudinal evaluation, whereas other tools are not. I've heard that the MOCA is not meant to be used longitudinally to see cognitive decline. And I was just wondering if you could talk a little bit about that as well.
Yeah, thank you for the question. Wonderful questions, both. So for the first one, you're right. I mean, the Best Practices Task Force continues to say that there's not enough evidence to recommend routine screening in the primary care setting. And, you know, I wonder about that. And I wonder, you know, with some maybe different ways to look at that, if that evidence would emerge. And I think ultimately we will get there, but for the time being, I think, yeah, that advice of maybe focusing more on case detection for individuals for whom you have a concern or they can have a concern. But I will say, you know, the fact that the Medicare annual wellness visit is a benefit of Medicare, and one of the mandated components of that is cognitive screening. You know, of course, there's no guidance about what you do. So for a lot of practices, it's do you have problems with memory? And nope, okay, check, you know, on we go. But you have an opportunity to build something more robust into that. So you can do your practice as you see fit. As for the longitudinal, you know, cognitive assessment, you're right. The MOCA was not intended that way. I usually think of the things that are somewhere between a neuropsych eval and a MOCA or other screening tool like the Addenbrooke, or there's some longer mental status, you know, the 3MSE even though I wouldn't recommend that. So those have a little bit better data around reliable change, you know, and I think about, so somebody's in your office or in front of you, we're at a memory screening and they get a certain score on the MOCA, and, you know, there's that person's true score and then there's the error around it. And then say, you know, and that error might be random or it might be fixed error. And then say they come back in 6 months and now their score is here, but that error is still like this. I mean, it could be that that's not a reliable change. And the psychometric properties of the MOCA and similar instruments make it very hard to determine that, whereas these longer things are better for something like that. But they take time. They usually take some training to administer. You can do it with you know, speech and language providers or other folks. Allied healthcare providers can do it. And then the last thing I guess I'll say is, even though they weren't meant for that, typically when people get to a certain level of change or based on their preferences, you know, I will say, this is somebody that you should not send back for another neuropsych eval. This is, you know, 2 or 3 hours of torture for this person, and you can probably just follow them with the MOCA, you know, below a score of 16 or 14. So you can do it, but you always have to be mindful of that amount of error. And boy, is this a significant change or not? Good questions, though.
Thank you.
Yeah.
Great question. Can I just add one more thing? I
Please.
agree with everything that you said. And I think that if we take a step back, and you presented this data, I think during the first talk that we gave as our kind of inaugural talk, we know from studies that fewer than 1 in 2 people who are living with cognitive challenges are identified in primary care. And we also know that there's a lot of challenge that certain communities are facing around discrimination, around racism, around feeling devalued for their concerns, around their health, their well-being, their cognition. And so I think, and furthermore, yes, the best practice task force does not recommend screening widely. And whereas the American Academy of Neurology, another national board, does recommend this screening because, and I'm not going to go into all the reasons, but because it improves the quality of life and the experience, the lived experience of someone, if we can identify things earlier and address and care for that person. So that's a different perspective to present here as well. And also just within that context of people feeling that their concerns are not heard. As you said, you want, if somebody's asking for this, let's take it very seriously. And I think you made that point as well. So, and then the annual wellness visit is this federally mandated annual opportunity, not only to address prevention, but to really do this type of case detection. So thank you.
Yeah. Other thoughts, questions, things that you use in your daily life that have been helpful? Or
This is Amber, and I just had a quick question. Because, especially an hour-long visit is really a lot of information. Do your care coordinators or somebody kind of touch base with the patient or the family like a day or two later to kind of do some clarification? That was a lot of information. What kinds of concerns? What's your biggest concern? Just to kind of piecemeal it a little bit.
that would be that's a fantastic question. And when we were just starting out and had the bandwidth to do that, yes, we were. And then once we got to a certain size, it's been more challenging. We have a social worker and a few nurses that will do that. And then, there are allied folks. So the best partnerships have been the ones between us and primary care, where the person is going to follow up with their primary care provider in a week or 2 weeks, and they get a chance to maybe touch in on some of those things too, or they come back for a cognitive rehab session or some other kind of a service. The other thing that we have done here is to partner with the Alzheimer's Association to really make sure that it's almost like a care coordinator. So we've got some connectivity there that can happen, and leveraging the relationships with your excellent partners but yeah, that piece of what people leave with questions. Questions come up an hour later, a day later, a lot that they didn't understand. I think in the best models, there is that kind of that coordinator or facilitator that checks in on that and ensures that things don't fall through the cracks, like the recommendations or the referrals, or even a prescription of, well, I called this in, they never got it.
Right.
Yeah.
Yeah, I really think that those community-based resources, especially now with COVID,
Huge.
can take some of the heat off of our healthcare system, and they offer some things probably socially that a doctor's office can't.
Yes, this is Kim, and we are the Alzheimer's Resource of Alaska, not the Alzheimer's Association. I just wanted to make that clear. So yeah, and we do offer a lot. So thank you for Dr. Rhoads for bringing that up at the end. I also wanted to mention a couple things that I wrote some notes here. You had a lot of information. There are a lot of good information, but I wrote some notes here. So I wanted to talk a little bit about something you said before. You said, as soon as a diagnosis is given, the conversation tends to only be between family members and the medical person who's giving the diagnosis or whatever. And I wanted to, you said something about making sure to include the person with dementia. I just wanted to say that is so important. And a lot of times that's something we hear about here at the agency when folks come to us and they come for a consultation and they come in and say, that's one of the things we hear a lot. That's why I wrote it down. And I just wanted to say that really is important, to make sure you include the person with dementia. And even if they're nonverbal, even if they can't say things, just, looking at them, and there's lots of ways you can include someone with dementia as part of the conversation, just validation of who they are and all of these things. And so I thought that was really important. And then the other thing is plain and sensitive language, especially for people in the rural areas. They're translating, from into, English is their second language. And so they have to translate. So really trying to cut down the words. English, there's a lot of words and we use a lot of words, too many words. That's what we say in Yupik. It gets overwhelming sometimes. So think of those things. And I don't think it's only the Yupik culture, it's probably other cultures as well. So really using plain and, sensitive language. Anyway, I just wanted to say that. Thank you.
Thank you. Thank you so much for saying that, and it's, you also raised the point of really being clear and having the conversation around how do you want to talk about this, and we, some of the populations that we work with here don't want to use the term dementia, and that's fine. That is absolutely fine. And knowing that, and then finding other ways to talk about it and still address what needs to be addressed, but making sure that we are checking on that way, way, way up in the front end of things is so important. I saw a couple of chat messages here. One is that, sounds like the ARA has a prescription pad that allows doctors to refer the family to us for follow-up. That's another great way to do it. Take the pressure off the person with memory loss and the family. Yeah, yep, that's great. Well, we've got about 13 minutes or so, give or take. And Dr. Eisenberg, I think you had a short vignette that might spark some conversation. I would love to hear from folks, again, what has worked for you and what has been helpful. So I'll let you take it away.
Okay, thank you. Just make sure that you can. Are you seeing case presentation or no?
Yeah, it's the presenter view, kind of the.
Okay, hold on.
Yeah,
I'm going to change that.
There you go.
Now, are you just seeing case presentation?
It's perfect.
Okay, beautiful. Okay, so this hopefully will integrate a lot of what we've talked about, this rich conversation. So imagine you're in your busy primary care office and Ms. Remy Embers is a 79-year-old right-handed retired librarian, and you've known her for some time. And she has hyperlipidemia and osteoarthritis. She lives on her own, and her daughter, Carrie Guyver, is visiting on weekends. So usually she comes to her visits on her own, but this visit, her daughter comes and corners you between rooms to share her concerns that her mom has been getting more forgetful. She looked at her pill box and she hardly took her atorvastatin last month. She also lashed out at her daughter, accusing her of stealing the necklace, which she later found in the drawer. And she mentioned that there was a dog that she'd seen in the fenced yard, but Carrie hadn't seen this dog, so she wasn't sure about this. So you enter into the room, into the office, and you ask Miss Embers how things are going. And you add, have you noticed any memory changes? Right then, she becomes upset that you ask and accuses her daughter of meddling. Okay, so we can just pause, and what are your thoughts about this vignette? Have any of you seen this in your office or encountered that? How have you managed this? How have you kind of included the two perspectives, and who have you centered? Shall I stop share for now and then we can see everybody?
Sure.
Yeah, I've heard from family members who had this happen.
Yeah, multiple times actually. And
Multiple-
they're pretty upset by it when that happens. They said, oh my gosh, I didn't mean him to do that. Why did he do that? Why didn't he know that blah, blah, blah. You know, I'm not going back to him ever again. You know, I'm going to make my mom go somewhere else. You know, that kind of stuff. Maybe not quite so dramatically, but.
What do you think? Ways to approach this? I mean, I know how I would handle this, but I'm curious how others would deal with the situation, because it does happen.
You know, and she's your patient and you have a relationship with her. You've seen her over time. She's been doing well, living on her own. And this is new information. That's important information for her well-being too, and her safety.
Well, you know, I haven't been in that situation where I've had to give that information to anybody, but it would be criminal if you didn't address it. You know, again, back to that early diagnosis. So, you know, I don't know how you would lead into that, but I mean, you could certainly do a mini cog right there on the spot.
You could, and I think you're right in terms of, you know, you have to address it. The question might be, how do you do that in a way to preserve the relationship and not, not have a difficult end of the visit when they have to leave. Yeah, and I would offer it too. I mean, even if you don't see patients and families directly, or at this point in your career, if you have thoughts about ways to navigate that, I would open it up.
Hi, I'm Steffi Kim. I used to work in a primary care clinic, and we did see patients with dementia. And I think one way might have been to ask if they're both okay to join the room and step in, and then to see just kind of maybe rephrase some of the concerns that had been shared, and if the patient maybe also had experienced something similar, or if it's totally different, kind of just to get a sense of where these things are coming from. And most of the time, the patient also has recognized something, but there's anxiety or different things involved. So opening up the conversation could really lead to, just even attending it. Not so much testing right away, maybe just kind of assessing what's happening in the room and with the two of them, and start from there.
Mm-hmm. Yeah, excellent. Excellent. I'll echo that for a second in terms of, I'm also fond sometimes of saying, like, well, there's always three sides to every story, his, hers, and the truth. And it's a way to potentially set the stage for, maybe it would be a good idea just to get a baseline, an objective baseline. Would that be okay? And if they say no, then okay, well, maybe we'll chalk that up for the next visit. But, when there are disagreements in perceptions of how someone's doing, you can sometimes use that as an intro to, well, let's collect some more data. Doesn't always work. Other ways people would address this or handle this kind of situation? Nancy, what do you do when it happens? Oh.
Yeah, So I agree with you. I mean, I think the most important thing is that emotional connection in the room and building trust, and you know, acknowledging that the person who's experiencing the cognitive challenges is the pilot. That person is in the primary seat in the, as you know, which you made that point really very well, Chris, in your talk, but in this kind of triad visit, and at the same time, you need that information from the care partner, because you know, we want to make sure that everyone is safe and thriving with the challenges that they're confronting. So sometimes I like what you said, you know, it's a Rashomon kind of, who knows what the truth is, right? And at the same time, you stay curious and you can get some data. And what about financial vulnerability or medication mismanagement? I mean, these have implications to the well-being. So you got to get that information in the visit. So establishing rapport for sure. Sometimes I have felt like I'm the ref, you know, like between people. But that ground rule of the person who's your patient is the primary person that you're going to listen to first. That person cannot be interrupted. Those types of things, I think, can set some very basic ground rules that can help with the confidence of the individual in the moment and the sense of agency in the experience of the loss. You know, sometimes people are lashing out because they're afraid. Sometimes they're lashing out because we don't, you know, it can be a variety of reasons. So what about these concerns about, so there's all sorts of ways to sort of unpack this case, but those are some of my approaches.
Yeah, I appreciate that. I think, you know, if we go back to the spikes model too, that the P is so important, the permission, right? To ask the person's permission that, you know, is it okay with you to get your daughter's input here? And if they say no, you have to respect that. You can then say, well, you know, it sounds like your mom's, you know, more comfortable with us not talking directly. You're always welcome to write down your concerns and send them in, or send them via a chart message. I mean, there's other ways to get that perspective, but that, you know, I guess the other P is the preserving of that relationship. Yeah, and it really is an opportunity to discuss that, you know, these concerns are by and large most of the time coming from a really good place, that they're worried and
Right. And I think the spikes model is something we can review again, and then also that age-friendly approach where really fundamentally what matters to your patient, to the person, what matters to that person fundamentally. And then again, you know, getting a mentation assessment, medications, mobility, and, you know, mind diet. So there's also, that can be a helpful frame as well with what matters.
And to the response in one of the chat questions, I have, in terms of following up, there have been times where I have reached out after I felt like I screwed something up, like, or I didn't handle that as gracefully. And so you may call afterwards and say, boy, you know, I'm so sorry about yesterday's visit. I just wanted to check in, see how you were doing after that. And it doesn't need to be a long conversation, but it's another opportunity to discuss, well, here's why I brought this up, or here's why, you know, I was responding to your daughter's concerns. Again, doesn't always work and takes time, and but yeah, I think there's always opportunities to follow up. And the other part about the spikes modification and dementia is that the summary, when you ask permission to, is it okay to go on or to talk about the diagnosis and what's next, if they say no, you can say fine. And then, is it okay if we schedule a visit with your family later on, or is it okay if I reach out to your daughter separately tomorrow over the phone? And often people will say yes, or, you know, so it's more of a, how do you can be flexible, but.
And then I appreciate in the chat this, you know, keeping a journal, and it can be a very diplomatic way to communicate concerns before the visit through my chart, or even in a discreet letter, so that, you know, you're making sure that you're addressing everyone's concerns, but not in a way that inadvertently causes somebody to suffer more than is necessary to maintain, safety and well-being.
Oh, that's a great one. Comment from Liam that if appropriate, we'll also offer a home visit to assess any needs to support independence. Boy, which is a fantastic service as well. You also get to check out the environment and get a sense of safety. And yeah, what a great service to be able to offer. Any other thoughts in these last minutes here? Other things that have worked well for people, or we don't always get it right, but I think we all have found things that work. Well,
There is a question in chat. If the family member has a power of attorney, can you talk with them without the permission of the patient?
yeah, you can. You need to figure out how to dance with that one, but yes. Yeah, I still, even, it's like working with kids where you still want to get at least verbal assent, if not full consent, right? Where it's like, if they can agree that, okay, fine, it's okay if you call, that's the best case scenario, but sometimes it doesn't work that way.
Okay, well, it is 3 o'clock, so thanks.
3 o'clock, uh-oh. Time warp.
2 o'clock, 1 o'clock.
It's some other o'clock. Yes, thank you. Thank you for the reminder here. Out of respect for your time, whatever o'clock it is where you are, I will we'll sign off, and keep an eye out for your survey that will come through, evaluation, and then we'll see you in 3 weeks by democratic process.
Thank you.